Hello, Insta family. It is Dr. T here on Tuesday night, ready for our rapid fire Q&A. I hope you guys are good. I have just realized that I'm wearing exactly the same top I was wearing last time we were on live, which was not last Tuesday, but the Tuesday before. So I got to change up my wardrobe, hey? Or maybe this is just what I'm comfortable in on a Tuesday night. I don't know. How are you guys? I hope you're really well. I had the most magical experience last week. Did you see my pictures? Oh my goodness. Hola, Barcelona. Wow. What a great time. I've never been to Barcelona before, and I have 11 new best friends from all around the world. A whole heap of fertility specialists got together for a little bit of a brains trust. And it was fantastic. Really, really enjoyed myself. Learnt some amazing things. Learnt that a lot of fertility specialists all around the world experience exactly the same challenges. So we are not that unique in Australia. There are a lot of things that we are equally challenged by, no matter where we are on the globe and no matter the language that we speak or the cultures that we have. We're all kind of challenged by the same things. So yeah, really great experience. It was literally a 48-hour turnaround. I was there for 48 hours. I did hop on a tour bus and go for a little bit of a look around, so I got to see a Gaudi. I can say now that I've seen a Gaudi. I saw Chris Columbus pointing towards the Americas, which I believe is not the Americas, but it was good. It was good. And I ate tapas. Yes, I ate tapas. Even though my trainer has me on a very strict diet, I still ate tapas. I didn't drink though. Now, let's do some Q&A, hey? Somebody has posted or DM'd me a question, so I'll get to it in a second. So if anyone has any questions, please drop them into the comments section. Make sure you don't tell me your life story. Make sure you make your question as generic as possible. And you know that the answer will be applicable to everybody. Oh, Kayla's right in there. Kayla Jameson first popped the question in. Well done. Thoughts on metformin for trying to conceive if you're already ovulating, confirmed with bloods? What else is it used for if you are already ovulating, healthy weight and regular cycles? Great question, Kayla. Well, there's a lot about metformin that we don't actually know how it works, but what the evidence does show us is that if you are doing ovulation induction on somebody who has polycystic ovarian syndrome and they have a BMI that is under 30, so their BMI is under 30, they're not overweight, they have ovulatory dysfunction. So I'm going to come to your question in just a second. They have ovulatory dysfunction, and so therefore you're doing ovulation induction as a form of treatment. So you check the tubes are open and you've checked that the sperm is normal. What's the purpose of metformin? It actually improves pregnancy rates as an adjuvant. So we don't use it as an ovulation induction agent in its own right, but in a woman who has a low BMI, so she's already not a low BMI, but a BMI below 30, she has already optimized the lifestyle aspect of managing PCOS, and she's still got disordered ovulation, would suggest that she has a degree of insulin resistance that no amount of lifestyle is going to fix. And so therefore, the thinking is that the metformin will potentiate the action of your ovulation induction medication, be it Clomid, be it tamoxifen, be it letrozole, be it gonadotrophins. Metformin will improve ovulation induction rates. Now, it could work by other mechanisms as well. When it comes to someone like you, my friend, the real question is, okay, you've had a blood test to prove that you're ovulatory on one occasion. So unless you are tracking your cycle every single month using bloods and ultrasounds, you could still have disordered ovulation, i.e. it's not quite perfect. And so therefore, if the front half of that cycle, that stimulation from the brain to the ovaries is not quite perfect, the signaling's not quite right, the orchestra is not quite in tune, then the second half of the cycle is similarly not going to be normal. Hence, pregnancy chances will be reduced. So even though you might have a progesterone rise, i.e. proving you've ovulated, you may have disordered ovulation, which can still reduce your chances of getting pregnant, and metformin may have a role there. So hopefully that will help. Now, before I can see there's another question that has popped in there. Before I get on to the next question, I want to go back to the one that was DM'd me. Thank you very much, Laura, for sending that through. Sorry, I had to go into the recesses of my mind. Now, Laura was asking the question, what are the rates of success for a woman in her 30s who has infertility and known endometriosis? What are the chances of conceiving with IVF? That's a really difficult question to answer, to give you an exact number, because obviously it depends upon how severe the endo is, how it's being treated, perhaps how old you are. Okay, you said in your 30s, maybe how old your partner is. So there are quite a few confounding factors that could impact on your success rates. And a woman at 32 is very different to a woman at 39. But here's how I'm going to pitch it. I thought, how can I explain this best? Let's say you have a couple where the only issue is the woman has blocked tubes, right? So IVF was designed for that, to bypass the tubes. So the only issue is blocked tubes. You have another woman who is the same age and she has endometriosis, but her tubes are open, she's ovulatory. Let's say they're both the same age, so the age factor issue is not an issue. And there's no male factor infertility in either of them, right? So the only difference is she's got blocked tubes and needs IVF, and she's got endometriosis going through IVF. The woman with endometriosis will always have a lower chance of success with IVF than a woman with blocked tubes. Endometriosis impacts on multiple different levels. It, number one, can affect egg quality. It can affect embryo quality. Obviously, it can cause blockage to the tubes, but it can set up an inflammation in the whole pelvis that just makes the environment very hostile for an embryo. And it can also reduce the chances of implantation, therefore, into the endometrium. So you can create embryos outside using IVF, and you can put an embryo back and put an embryo back and put an embryo back, and still she will not conceive because of that inflamed, hostile environment. Not only that, but it is thought that women with endometriosis also probably have a progesterone receptor issue, hence why they've got endometrium growing outside the uterus itself. Their surveillance mechanisms are poor. And so because they probably have some progesterone receptor issue, then their response to progesterone supplementation may actually be less. So because of that, a woman with endometriosis will always do less well than, say, a woman with blocked tubes. Now, does that mean you can't get pregnant with endometriosis? No, it doesn't. Does it mean that you're probably going to need more goes, perhaps more IVF cycles or more embryo transfers, or maybe even the creation of embryos and then suppression of your disease with medication before you put an embryo back into that environment? Yes. And so if you have known endometriosis, I would always say to you, make sure that you stay on suppression as long as you can in order to keep that endometriosis suppressed. Come off any of your suppression. Start trying straight away. Don't dilly-dally. Don't wait till you go on holidays and try for that romantic weekend. You start trying straight away. You give yourself no more than 6 months. We don't wait for 12 months in a woman who has endometriosis. You give yourself 6 months, because in that 6 months, the endo is just going to come back and we're going to be back to square one again. And generally speaking, if a couple presents to me with endometriosis, more than likely I'm going to direct them down the IVF pathway, and I'm not going to dilly-dally with any lesser treatment, because I want to try to help them get pregnant before that endometriosis really takes us past the tipping point. Okay, so Laura, I'm really hoping that that was helpful for you. Okay, Nina Person. Trying to conceive for more than a year, found out that my partner has a low sperm count. Well, 15% of infertility is male factor related. and low motility. Okay. Any advice on improving quality and try to conceive naturally? Thank you. All right. So the first thing to know that unless he has zero sperm, there is always a chance of conceiving spontaneously. So the chance is significantly lower if the total motile sperm count is below 5 million per mil. So you need to go and have a look at that. But certainly there is always going to be a chance. So it depends on how low is. It's also important to consider what may be causing that. So is it because the brain is not stimulating the testis to produce sperm, i.e. it's a central problem? Or is it because there is a problem within the testis itself, or perhaps an environmental problem, i.e. toxins, for example, or some sort of illness? So any man who has an abnormal sperm count will often from me get a physical examination to make sure there's, I can feel for the vas deferens that joins the testis to the outside world on both sides, to make sure that there's no nasty lumps or bumps or even the presence of a varicocele. And then I'll always order an ultrasound, because we want to make sure that there's no mass in the testis, there's no big swollen varicocele, there's no other pathology. We'll order blood tests to see, is the problem centrally, is the problem in the testis? And really it depends upon those things that to determine is this a fixable problem. Mostly we can overcome it with ICSI, but is it something that can actually be fixed to normalize the count and the motility? Hopefully that is helpful. Thanks for asking the question. Really good one. All right, Tash Reed. Does it really matter what kind of prenatal vitamins you take? No. Are they all the same? Pretty much. Is one better than the other? Not really. Will they actually help? Yes! The most important prenatal that you need to be on is folic acid. If you do nothing else, go and get yourself a bog standard, cheap as chips folic acid. You need to be on 500, well, the Australian guidelines are 500 micrograms per day, in addition to whatever you're consuming in what is considered to be a normal diet. Folinic acid is not a substitute. There is no research on folinic acid, activated folate, any of that stuff. There is no evidence to show that stuff will reduce your chances of neural tube defect. So just saying, for all those people who are being prescribed methylated, activated folinic acid, no deal. Folic acid is what is recommended. People who are on metformin, people who have had previous neural tube defects or themselves have had a neural tube defect, and some medications, I'm not going through them all, require you to be on a higher dose of folic acid. Speak to your GP about that. All of the other nutrients you can get in a balanced diet apart from vitamin D. So checking your vitamin D is valuable. I don't always do it because we live in Australia, but women with dark skin, for example, who live in Australia probably need to check, make sure their vitamin D is normal, or those who might wear a head covering or hijab. It's worth checking. If you're a vegetarian, check for your B12 or your iron studies. Iron's really important. And only supplement those things if they're abnormal. But truth speaking, if you're having a moderate diet, which includes fruits and vegetables, lean meats, dairy, yes, gluten, if you are including a diet that has those things in it, i.e. a Mediterranean style diet, fatty fish, salmon, then you are able to get most of your nutrients from your diet. And if you're not, then it's reasonable, though not necessary, to supplement the others. So that's the supplement story. Okay, any more questions? These are great, by the way. Love them. Love them, love them, love them. They're important questions. Thanks for asking them. Any more? This is really good. Okay. Can't see any more, so if you do, just jump in there. I want to talk about something I saw on Big Miracles last night. I firstly want to give a massive shout out to all of the team, the fertility specialists, nurses, sonologists, obstetricians. I know them all. They are incredibly intelligent, and dedicated and passionate fertility specialists. I love them all. You guys are amazing. Many of you have been my mentors, and I really, really appreciate that. And many of you have been my friends. I am, however, going to give you my point of view because I can. I know at the moment there's a story about a 46-year-old woman and her, I think, slightly older husband. And I am like that this couple will conceive. I know they had tried to conceive with frozen eggs that she had frozen at 38. Unfortunately, didn't conceive. I hope that I am not telling everybody and they haven't watched it yet. But what I want to say is this. The chances of you as a 45-plus-year-old woman of you conceiving using your own eggs is almost negligible. So I'm going to throw out a statistic of 1 in 200, right? In fact, some very clever mathematicians have done some mathematical modeling around this. And what they've shown us is that if a woman is 45 years of age, it's going to take her 80 IVF cycles for her to conceive using her own eggs. Like, no one's going to go through 80 IVF cycles in order to conceive. So I don't know what the outcome is going to be for this lovely couple. I really hope nothing but the best for them. But should they conceive in this amazing program, Big Miracles, I can promise you it is an absolute miracle. And it is not something that we should expect to occur, because there is a lot that really they're up against. And one thing I want to shed some light on that older couples are up against is the aged egg and the aged sperm. So there's this amazing thing that happens when the sperm it fertilizes the egg. That fertilized egg is called a zygote. And there are mechanisms within the zygote that kind of monitor the sperm DNA as it comes into the egg. And it monitors it for the amount of DNA damage that it has. Now, older men, and I'm talking men over the age of 40, definitely over the age of 45, will have higher DNA damage in their sperm just by virtue of them being older. We know that older men will have a higher percentage of their children having autosomal dominant conditions. Dwarfism is one of them. So we know that men's sperm quality does decline with age. Where we come a cropper and where there is the perfect storm is when, okay, I'm not explaining this very well, but when the sperm enters into the egg and becomes the zygote, there are these surveillance mechanisms that look at the DNA of the sperm, and if it is damaged in any way, these repair mechanisms within the zygote, they come from the egg, will start to repair the DNA damage. Amazing, right? Amazing that an egg can do that, because it's got all these internal mechanisms to do that. However, if the egg is also old, these DNA repair mechanisms don't work as well as they did when that egg was younger. So if you have an older woman and you have an older man, part of the issue around an embryo grinding to a halt after it's being fertilized is those poor DNA repair mechanisms in the egg, unable to repair the high DNA damage that is in the sperm. And that is something that many research bodies around the world are trying to improve. And, you know, we bandy around coenzyme Q10 and melatonin and all of these things that we are trying to improve the quality of the embryo with by trying to fix these processes. We don't really have any good evidence yet. We don't have any evidence that this stuff actually really works. So that reality check, right? Point of view, but reality check is that the chances of a woman conceiving, doing IVF with her own eggs, no matter how many she has, even if she's got a really good egg count, the chances a 1 in 200, 0.05%. Like low. And it's all very well to give it a go, and you might be that one, and we all hope you are, and I would definitely be in the same place, but I think it's important to understand what the chances are. What other ways could you choose? You could go an egg donor. And even if you used the sperm of your older husband, if you had a younger egg, those DNA repair mechanisms are working, right? So you're going to be successful. And that is what we often see is older women getting the eggs of a younger woman with their partner and conceiving with donor eggs. You could go donor embryo of a younger couple and then completely overcoming the aged egg and the aged sperm thing. Or you can just keep trying yourself. But there will come a time where you run out of eggs. And for many women, that is on average 50 years of age, right? 50 years of age or 51 is the average age of menopause. And there's nothing really scientifically that we can do to change that. So we are trying to freeze eggs, and I do think there's some validity in doing that much younger than 38. You know, we should be encouraging women to freeze their eggs in their early 30s, really. So I think that is definitely, but like that requires a bit of crystal balling, doesn't it? Who's to say? Who's to say you're going to need to use them? Only 1 in 10 women come back to use their frozen eggs. So I wanted to just put that out there, because when I saw this on Big Miracles, as much as I went like everybody else, and as much as I'm sure that couple were doing that, I think it's really important that everybody understands what your actual chance of success is, because television can sometimes paint a better picture, can't it? Any more questions? Come on, there's got to be some more. There has got to be more, or you're just blown away by my story. Any more questions? There's got to be some more here. Thank you everyone for coming on. I recognise a lot of faces there. Lovely to have you. Hey, question for you guys who are still on. What do you reckon if we did a Tuesday night live where I invited one of you on live to ask your questions? Would you be brave enough? Would you want to come on and have a conversation with me live? If that is something that you think, yeah, that's something that I reckon I could do, I've got a ripper question for Tamara that I think a lot of people would value. Is that something that you guys would like to do? Because if it is, I'm rather tempted to give it a go. We'd have to have some rules and parameters. So if the questions get a little bit too deep, or it's not respectful of me or anyone else who might be listening or watching, then we just shut it down. But I'm wondering if it would be good for people to start sort of sharing and asking live, because they're fantastic questions. They really are. And you might have 2 or 3 questions that you want to ask in one go, and we can just have a little bit of a, yes, Brit's loving it. Life of Brit is loving it. That would be cool, wouldn't it? I got to tell you, it's not my idea. Lucky Seacon, I definitely recommend you go and follow her. She is one of the doctors I had the opportunity of connecting with when I was in Barcelona, and she does it with her American crew. And I thought, that's really neat. That's really scary, because you never know what you're going to get, right? You know, that old saying of never work with children and animals. Not that I'm saying you guys are children or animals, but you kind of don't know what you're going to get. So, but I think it would be cool. So Life of Brit, it looks like you're in. I wonder if anyone else would be in. I think we might try it. We won't do it next week because I've got some colleagues in town. But let's aim for, hang on, let me get a date. Let's go for the 14th. Tuesday the 14th. Let's do it. Tell your friends to jump on. We'll hop on Tuesday the 14th and we will do a live, like a really big live. And I'll invite someone who wants to join to ask their questions live. That would be really cool. All right, Groovers, I've just gone down to 5% battery. I better get off. Have a beautiful week. Enjoy the heat. Enjoy the last rays of summer. And I will see you guys next Tuesday. Bye.